Good evening. I'm Josh Firminger, data scientist at Optum, and this is my colleague Jake Secor, data scientist in product management at Optum as well. We're really excited to talk tonight. We're going to have three main themes. One is who we're doing this work for and why we're here in the industry. The second is pace, so how quickly or how slowly are we moving? And the third is really around accountability. And accountability to not just the quality of the solution, but actually how we want to prioritize and use them. Actually, before I go to the next slide, I love the title that we have because there's two meanings to it. Be patient. And the reason I like that is because I think healthcare moves very slow, and I ran track and I ran the 400, and if you ran slow in the 400, people were crossing the finish line before you turned, and that was very bad. So be patient is kind of an ironic statement here, and I'll explain why. The second is because in the way that Optum and Optum Data Science and our team thinks about this is we have to not only be patient with the process and the system, but we have to be the patient. We have to put ourselves in the shoes of the patient and build out solutions that actually matter and actually are going to impact their day-to-day experience and their health. So who is Optum? We'll just brush over these. We're huge. You'll probably get the slides after. We're part of United Health Group. Go buy our stock. We went down last week. But Optum is a massive company, and we are a big part of United Health Group. Our sister is United Healthcare, which is in the health insurance, health benefits, and Optum is very much centered around health services and many different components of that, Optum Rx, Optum Care, Optum Technology, Optum Insight, et cetera. There's new marketing that came out. You could probably see it on YouTube. I don't know if we were paying for marketing ads on TV. It's around we are the how. So what does that mean? In my mind, what it really means is we're everywhere in healthcare. So we are the how because we're all in all places. So we have enormous breadth in what we can touch and what we can feel. But really what that means is we have a lot of influence and responsibility to how we solve healthcare problems. What are we trying to do from a data perspective? What are we trying to do from, well, probably what's most relevant to this group is we're trying to use the footprint that we have, the 240 million lives that we have at our disposal to really impact how the system functions and works. I had wine before this, so I'm getting very dry mouth, so I'm sorry. What else is Optum doing? So we're collaborating with researchers. We've put $3.5 billion in funding behind. It says innovation on the slide. But really what we're doing is we're trying to put investments into what we are essentially betting on is what's going to change healthcare, what's going to help the consumer, and what's going to help the greater enterprise. So I said there were three themes. I've kind of referenced them a few times already. Pace, who we're doing this for, and accountability. But really, what we'll start with is the problem. And the problem is, and the use case we'll talk tonight and the solution that we'll talk about tonight is very much about disease and chronic disease and disease progression, as well as individuals who are not being diagnosed with a chronic disease. These are big problems that have major financial outcome and experience impacts on a consumer's life. We'll talk about one just kind of briefly here, Afib. 20 to 30%, clinicians are not actually able to diagnose or not be actually able to diagnose very quickly. It's a problem because that has an impact on this individual's life, a real health outcome. They brought a water. Bear with me.
He warned you he was.
I did say that, yeah. So these AFibs going untracked, these are also very costly. So if, not only is if someone an individual has a stroke, again, very bad outcome, we don't want that, but it's also an impact to the economics of the system. And the reason we're talking about this tonight is because this is actually something that we have interventions for. So one of the things we'll talk about is we think about who we're doing this for. We're doing this for people who have these diseases, who want to live healthier lives and have better outcomes. But as a service company like Optum, what we want to do is we want to facilitate the right interventions and the right actual, clinical, proven steps that we can take to mitigate these diseases or help these diseases, and connect those to the patients who actually need them at the right time. So, think about this example. I'm Josh. I'm going undiagnosed for AFib. We can facilitate. I'm at risk, and we find that we can facilitate the right interaction before that person has a stroke or I have a stroke. So that's great. We want to do that. I think we all want to do that. If we don't, my gosh, what? Okay. I won't share Drake. No, I'm just kidding. But we need to go faster. So really what we think about this as is like at Optum, we're a very large company, and there's a lot of different opportunities to invest capital. As a healthcare system, it's also compounded in complexity. There's so many different components. We've heard from a couple others tonight. But there's so much going on. There's so much complexity. And having the context at the right moment is very hard. But as a data scientist at Optum, the only thing I truly care about is how quickly can I get to developing the model or doing the analysis that provides the insight that can help that one person or help those N of people who need it. So pace, how we accelerate to a solution is very, very important. But it's also how you generalize. So we, on our team, we work very, very closely. I'm no MD, and I never will be. We work very closely with our medical directors to really understand clinical outcomes, to really understand the kind of health components that surround not just the technology, right? I'm a technologist. That's what I get excited about. But again, I'm using technology to solve a healthcare problem. So what we want to do is we want to take a ton of use cases like AFib, where we have a problem and we have an intervention, and we want to develop algorithms very, very quickly and at scale that we can actually start facilitating the right interactions. So awesome. We needed a reusable modeling process. So I won't kind of go into too in-depth to each component here, but we have claims, we have clinical data, we have pharmacy, labs, et cetera, et cetera. It just says claims, I think, on here. But really, we have an enormous breadth of data. We have the ability to, with our clinicians, use that data to define the appropriate cohorts for a disease we want to predict or impute or whatever it might be. And what we've been able to do, and what we were able to do very quickly, about a year and a half ago, is generalize this. So generalize the workloads, the code sets, the collaboration to actually start producing these algorithms very, very, very quickly. But we ran into some issues: scale, reliability, and really it's those two. But also, what I would also add is reproducibility. Is something that we had not just an issue with, not from a reusability perspective, but reproducibility within the depth of the actual individual model lifecycle. So where did we turn? And we are at a Databricks-sponsored event, so I bet you could guess the next slide. Here we go. Scalable modeling process with Microsoft Azure using and leveraging Databricks. So we put in the components and applied the components with Azure Databricks to really help us streamline and solve those problems that I was describing, so that we can accelerate towards the actual healthcare solution. And the reason we did this is our team has a very strong philosophy that, as healthcare data scientists or as a healthcare engineer, we are responsible to not get distracted. We are responsible to not get distracted by rolling our own solution from scratch when there is something off the shelf that enables us to deliver the value that we truly want and impacts the consumer and the business much faster. So using things that are commodities to everyone in California that may not be a commodity in Minneapolis, that's where Optum's based out of, and taking those commodities, plugging them into our system, and actually focusing on healthcare problems. Benefits to this, we have scale through the unification of this, of the data munging, the data processing workloads, the model training. Through this unification, we were very successfully able to produce this reusable framework to generate these models at scale, and do so very, very quickly. So the conversations moved from how do we make sure we schedule these jobs appropriately at the right time, to the right kind of conversations, which are, well, why did the doctor say that our results didn't make any sense? Why did the doctor say that this individual was so much different than these other individuals? Those are the conversations that we need to be having, not how do I get my stuff to scale. This is a shout out to Tim Rosenflans and Joel Stremmel and Neil Kelly and some of the other folks on the data science team who, because we're able to kind of take away those infrastructure problems and focus on healthcare problems, we're able to then, again, put the right investment in the right areas. So leveraging some of the work coming out of Georgia Tech under Edward Choi and that team around Retain and the transparency architecture for EHR. We've been very successful of applying some of this research to Optum and actually contributed back to the open source community last year. And I think there's a group out in Seattle doing cancer research that currently has a PR that's out that we're hoping to merge. So we don't have 86 contributions, but we may have one, so shout out. That's awesome. Well, it's very good in healthcare because the reason I like this event tonight is we need more collaboration, and that's just one of my personal opinions. So things like this, open sourcing, providing transparency across organizations is going to be fantastic. One thing that I also get to say here is this research was trained on Mimic EHR data, what are these numbers, 263,000 patients, 14 million visits. We were able to train this on a lot more data than that. Let's just say that. And that's pretty much a phenomenal opportunity for us to really understand not just how do we produce the right outcomes and solutions, but also research. And how do we actually produce the right new architectures or new ML solutions or techniques that are going to help healthcare use cases. I love computer vision. I love learning the Medium posts, but I don't have a lot of healthcare claims, clinical data, Medium posts that I get to go and use to help me in my work. Those are all happening internally. And I see that as a big problem with healthcare, and we need more of that collaboration back into the community. So Optum's been participating in that. So I'm going to transition now to Jake Secor to talk about how Optum is really staying accountable here. But just as like a final remark for my piece, one of the things that we've learned in doing all of this, accelerating, focusing on the right problems, focusing on the consumer, being responsible with what technologies we're investing in. We're not done. I mean, we've heard a lot of amazing talks today and keynotes, and one of our opportunities is we are a company that's very, very mature in healthcare and very, very mature in components of technology. Where we're immature is bringing everything together. So we have an enormous amount of work that we are still going to be investing in and growing. And in my mind, having a mindset of like we have to continuously hammer on this problem that is the only way that we're going to be able to actually be able to solve these consumer problems. So there you go.
Awesome. Thanks, Josh. All right. So now I'm going to transition a little bit. My part of the talk is a little bit different than what Josh talked about. And what I'm going to talk about is how we keep our accountability for our members, our patients, even providers, and everyone involved in the healthcare system, because we do touch every part of the health system machine learning model can have. So I'm going to put up on the screen a lot of pictures here. And this is to demonstrate the difference between what we like to think of as high-stakes AI and low-stakes AI, or high-stakes machine learning and low-stakes machine learning. People around the conference today and yesterday have actually been using the terms high-stakes and low-stakes, so I'm glad to see that we're developing some consistent language there. This is the easy part of the presentation for an audience like this, because everyone here is in the healthcare life sciences room. So everyone in here hopefully already understands that we are in a high-stakes industry. Every decision we make can impact real people and will impact real people. Every person in the room is at some point in their life a patient. Everyone who we serve is a patient. And so that brings to the slide a little bit. I'll use an example of low-stakes AI being like email marketing. So if your model predicts that someone will be receptive to an email trying to sell them a cookbook, and the person does in fact buy that cookbook, great, that's a true positive, you did a great job. If the person doesn't end up buying the cookbook, that's a false positive. You've wasted the fraction of a penny to send that email. Maybe that person was annoyed by the email and they will choose not to buy your cookbook down the road when they're in the market. It's not such a big deal. On the other side, if you do miss someone who may have wanted to buy that cookbook, you missed out on the profits of selling one more book, but the person will likely still find a cookbook that they want to use, and you'll continue to have your marketing, and nobody's hurt. On the other side of that, we have things like prior authorization. In prior authorization, if a physician requests a prior authorization for a procedure for a patient, presumably the patient has something serious that they need a serious procedure for, and the physician is seeking approval that the insurer will pay for it. Us as UnitedHealthcare and Optum will pay for it. So if we insert a machine learning model in something like this, a machine learning model that we know is wrong some of the time, we have to be sure we know why it's wrong, when it's wrong, and if it is wrong, we have a plan to fix it. So here, if we do have a false positive and maybe we approve a procedure that should never have been approved, it's the wrong procedure that would have been caught in our normal processing, then we could have serious issues where hopefully someone doesn't actually have the wrong procedure, but we may have issues with the paperwork and the processing that does delay the procedure that they do need. On the other side, the really dangerous piece is if our machine learning model denies a prior authorization that's really needed. This is a scary situation where people may need urgent surgery. They may need some procedure that their family has flown to a specialty hospital to get. They're staying in a hotel, they're spending a lot of money to be there, they're taking time off from work, and our machine learning model just denied them their surgery. And had any person processed that prior authorization, they would have followed the steps, followed the regulation of the company, and they would have approved it. And that's a serious problem. That's where we can really ruin people's lives if we're not careful. So what we did when we kind of thought about this and thought we want to deploy some of these machine learning models into the healthcare system impacting real patient lives is we tried to think about all the different ways to go wrong. So we took the list of models that we had developed at the time and we broke them out into what turned out to be 4 categories. A large bulk of our models, as Josh mentioned, one of them, the Afib model, is a disease progression model. This could also include disease imputation models. And actually, so before I go into each one, I'll just briefly describe the picture here, and I'll go into more detail on some of these. So the y-axis in this diagram is the level of vigilance we need when we're monitoring these models, and I'll describe a little bit more about why we need to be more or less vigilant when I get into the examples. And then the x-axis here is how quickly reality is changing. So on the left-hand side, you're seeing that reality evolves. This is a case where you may not be able to day by day see a change in something, but gradually over time you'll see an evolution. And I'll give examples so it'll be more clear. On the right, this is where something can change instantly. It can change overnight, and you may not have any evidence that it is going to happen, and you don't know until it's too late. So I think in the interest of time, I'm only going to cover 2 of these, and I'll probably do it pretty quickly. But the first here is the disease progression class. This is a case where we need to be very vigilant in our monitoring, high on the y-axis, and it's an evolving reality. So I'm going to give an example here instead of reading all the words on the slides. We have a diabetes progression model that we currently have in production. That model looks at patients who have already been diagnosed with diabetes, and we're trying to predict whether they will become high-cost patients in the following year. And that's measured with, the model was trained on 1 year of training data, looking forward the following year. So in production, what this looks like is we'll get the data from the patients every month from the United Healthcare, the payer, their claims, and we'll run them through the model. We'll see what the prediction is, for the following year. And then based on that, if we do predict high costs the following year, they'll be routed to a nurse intervention program. So they'll get a call from a nurse saying, how can we change your lifestyle? How can we make you healthier? We see that you may become high cost. And in the case of diabetes, once you do become high cost, rarely do you ever become low cost again. So patients who have an exacerbation or something like they need a limb amputated, they start having diabetic retinopathy, their costs are high and will remain high for the remainder of their life. So the earlier we can intervene on these, the more money we save for us as a payer, and the less hardship the patient has to face when they do go through these procedures and have these conditions. So the problems here are it's a little bit hard to tell when we're right and when we're wrong. This is disease progression. They evolve slowly. This is reality evolving slowly. Diabetes usually doesn't just all of a sudden become worse. There are some precursors. It slowly ramps up. And so to truly tell if we're right or wrong, we need to observe for that following year, because that's our prediction period. So that patient may remain low cost for the first 360 days of the year, and then on day 361 and the rest of the year, they become high cost. So we wouldn't know that until we reach day 361. Now, if we do predict low cost and they become high cost early in the year, we know the model's wrong. We know that we were just wrong in that case. On the other hand, if we predict high cost and they don't become high cost until the very end of the year, we won't know until the end of the year, like I just described. But then there are more complications. And hopefully this isn't new news for anybody. We're all in this room. We may have gone through this already and resolved it, but we also have this intervention program. So when we predict high cost for a patient, they're getting that nurse outreach. If we have a patient who we predicted high cost and they don't become high cost the following year, we don't know if the model was wrong, the patient didn't become high cost and we wasted that intervention, or if the intervention worked, it was a perfect application of the model, they would have become high cost, we just saved a lot of money and hardship for everyone involved. We can't tell a difference in the data. So that's a challenge. That's a big challenge for this class of models. And we're rapidly trying to come with the perfect solution. We're working on monitoring data. If people hear concept drift, reality drift, things like that, that's a way to kind of a proxy for seeing model degradation is if the data looks significantly different than what the model was trained on. But it's not exact. It's an estimate. And these really are impacting patients' lives. Okay, only a couple more minutes, so I'm going to quickly run through the second one because I can hear they're already pouring drinks out there. So the second case is operational process automation. And this is still in the high monitoring phase. We're not going to get to the low monitoring in this one, but here reality is changing. And I'll use the example again of prior authorizations. Prior authorizations are largely regulatory. They're instituted by the payer because they don't want to pay for something that's not necessary or could be avoided. And so when providers prescribe costly prescriptions, for example, United Healthcare wants to make sure they've tried every other option before going to this costly prescription. And I'll again just use an example. And for this one, I'll say EpiPen. This is mostly a hypothetical example with a little truth in it, but a while back, EpiPens were not overly expensive. They were the preferred treatment for anaphylaxis, for allergic reactions. People could have them. I think most people are probably familiar with EpiPens. And so we would pay for them. As United Healthcare, we would say this is a necessary medication for people who go into anaphylaxis. They should have their EpiPen on them. But then all of a sudden, the price of EpiPen goes up. And us as a payer, we say, well, there are some other options on the market. We don't necessarily want to pay for this costly EpiPen. But keep in mind, the whole time EpiPen has existed, our processors have approved it. And so all of the data we have says EpiPen approved. And so every model we train to do these automated prior auths says EpiPen approve. But suddenly we don't want to approve EpiPens anymore. They're way too expensive. So what do? The model has no idea. The process just changed. The people all know. The model has no idea. And if we don't do something, the model will continue to approve these EpiPens. So here's where we rely on the subject matter experts the most. This is where we need to keep that human in the loop, like other people have talked about a lot. We need to understand when something changes. We needed a way to intervene with that model, divert some of the claims that are coming in for EpiPens, and say, don't touch them. We're going to do those manually. And as we do them manually, with our manual processors on the side, what they're doing is every time a new prior auth comes in for something like an EpiPen, they're generating a new training set. They're doing this manually. They have the new regulations. They're building up the data so we can retrain the model. And so like I said, that's mostly a hypothetical example, but it's just emblematic of the impact that we can have. So sorry I had to rush through that a little bit. We'll be around for questions if anyone has any. We just want to thank some of the people who have worked on this and open up to questions.
So, one of the questions that obviously comes up is what data are you guys getting other than the CCDAs and, the summaries of care? And do you think with the information blocking rule that is now impending and the activity that ONC is doing, this is going to change and you're going to be able to acquire more data directly from the patients?
So, let me jump in. Okay, so the examples we gave there are mostly off claims data. Because we're a part of United Health Group, we do have access to all of United Healthcare's claims, and they process a lot of claims. We process a lot of claims for them daily. So we kind of have that internal source of data that's a relatively clean data set because claims are on standard forms. And so we're able to bring in that data that we know, and we have a consistent stream for production coming in. And so
What about like actual clinical data, images, surgery reports, right? All of these other things that are now require data set. Yeah.
So Optum is, and United Health Group is so diverse. We are in the clinical space already. We are in the pharmacy space. We are in the claim space. So some of this, from our perspective, it's absolutely there's more ancillary data that we want and we think can help us, the data scientists, develop solutions that help the patient, et cetera. One of the projects that we were involved with is predicting whether someone's going to have an asthma attack. Well, it's great that we have clinical claims and some of this data, but we really want some of that data in that moment, right? We need to see what's the weather where that person is, or what's the weather in the home, things of this other nature. But that, in our mind, that introduces a whole nother round of complexity of data that from Optum's foundation, we can be very, very successful with the footprint that we have today. And I think there's obviously opportunities where Optum Greater is investing in acquiring some of this new data, but it's all within the belief of we bring it together. How do we actually first bring all the data together as we buy these companies, as we acquire more data, but then really just making sure that we're bringing the right data for the right use case. We're not just putting all the data in one big connected feature set and just running all of our ML solutions and frameworks on it. It's really making sure that we have just enough data that we need for that use case so that we're respecting the individual's privacy and all that stuff. So there's kind of two components of not just the acquisition of the data, but ensuring that our data usage is appropriate.
Thanks. Any additional questions?
Yep. I've got the mic.
Sorry. One of the pieces that you mentioned before was that you were finding things like preventative health measures such as discovery of stroke prior, Afib, and collecting medical history. And I'm just interested in what you do in both those categories to not just collect the medical history, desensitized, de-identified, I assume, but also what you're doing in terms of how you find that angle on preventative health.
So we have Optum Grader, right? So we're not just a technology company. We're really, I mean, to be honest, we're more of the services side. So we're services first. So we're in population health. We're in disease, within that, disease management, et cetera, et cetera. So really from a technology side, what we're trying to do is, right, so we have the medical history. We have years of claims. We have years of clinical labs, et cetera. What we're trying to do is develop solutions so that we can, have an intervention that we already have, a clinically proven intervention that we have for a use case that we can use and apply to be able to predict when someone may need that intervention and then facilitate.
Slightly, I'm offshore, so is that representative in terms of the population there? When you say we've got enough medical records to show that?
So when you say representative, my mind goes to, around commercial, Medicare, Medicaid. Is it more, in your mind, is it more that? Is it across all diseases? Yeah. So that's a big thing that we have to deal with is like, if we train on this data, but this data has, somehow a lot more diabetic individuals than the data that we're using in production, like that's a big problem for us. Right, absolutely. So, that's something that we, in Jake kind of covered this a little bit. That's something that we are mitigating. We are trying to mitigate. But it's so hard when there's n number of different diseases that we're trying to predict. There's n number of diagnoses that we're trying to predict. So a lot of the times what we've had issues with is we have a lot of one-off mitigations. So great, we've developed a reusable framework for modeling. Really what we're trying to do is focus on surrounding that with the right mitigations for exactly what you're describing, making sure that we are training on a population that is representative of production data. If not, making sure that we have enough data to improve that model, fine-tune it to that new population, and then do.
Yeah, and also to add to that, and it's actually later in the presentation, but post-deployment, when you're in production, how do you tell when the data that a certain consumer of the model is passing you looks significantly different than your training set? You may train on the most general data set you have, but if you bring in a new payer, a new provider or a new provider group, and they have a new set of patients, and their data is completely different, maybe they're in a different geographical region, maybe they're a different age group, we need to identify that the data that's coming in from this specific subscriber to our API or however they're consuming the model, their data looks way different than everyone else that's using it and the training set that we originally trained on. And we may need to take the model offline for that user and understand that they need a more custom model to fit their data.
Thank you.
Thanks.